So let's take a look at the post-birth issues here in terms of birthing and then breastfeeding of the neonate. So the birthing process itself is all about changes of hormones from both the mother as well as the fetus, and it starts with a abrupt truncation of progesterone that leads to the initiation of sloughing, along with signals of stress from both the mother as well as the fetus. If we look at the hormonal change that's going to take place, we're going to see spikes of HCG and HCS within the first 2 months, and then we start seeing a slow truncation of HCG over the last third to three quarters, last half to three quarters of pregnancy. This level of HCG is still going to be relatively high. However, it's not the big, huge spike that we see early on, and it's high enough to maintain high levels of progesterone and the estrogens. We will see a continual increase of HCS, which is the equivalent of placental growth hormone, until we see a abrupt truncation of HCS as well as a truncation of progesterone and estrogen very late in pregnancy, leading to the initiation of birthing. Now, this immediate truncation of estrogen immediately comes back. So we get this drop of estrogen and then an immediate rise of estrogen that is necessary for the birthing process and the post-birth care of the infant. This HCS that's going into circulation can become problematic because it's going to replace pituitary growth signals, which, if not reconstituted, can lead to issues of postpartum depressions for the mother, leading to inability to bond with the infant due to poor oxytocin release and circulation. So the initiation of the process is going to take place when we start seeing changes of cortisol levels and other adrenal hormones, starting with the fetus, working its way into the placenta and then into the mother, leading to changes of prostaglandin and oxytocin releases on the maternal side, and changes of progesterone, estrogen, and HCS, HCG from the placenta itself. All of these swings in hormones is going to lead to the initiation of uterine contractions within the myometrium that will initiate the changes within the urogenital triangles, allowing for birthing to take place. So let's take a look at the loops that are going to take place, and we'll take a look at the animation of the 3 stages of birthing: the dilatation phase, followed by the expulsion phase, followed by the placental phase. Now, within these phases, the largest and longest of the phases is going to be the dilatation phase. The expulsion phase is relatively short. The placental phase is going to be somewhere in between those two. So what we start off with some sort of stress. It's usually a fetal stress. This fetal stress leads to an increase of CRH. The CRH leads to an increase of ACTH. Within the maternal hypophysial, we start getting a release of oxytocin. This oxytocin is going to stay centrally. However, as cortisol starts to increase, we start to see changes within cardiovascular structures, which induces secondary stresses. The secondary stress, which includes a release of surfactant from the pleural lining, leading to the initial expansion of the lungs upon removal of the nasal plugs, is going to trigger a release of DHEAS from the adrenals. This is going to head across the placenta, initiating increased estrogen from the placenta. This increased estrogen from the placenta feeds back onto the hypophysial to instigate a release of oxytocin. So we've been building up oxytocin, building up oxytocin, building up oxytocin. As soon as estrogen washes into the area, all of a sudden it's and we get this stream of oxytocin going into release. When we combine oxytocin with estrogen and secondary signals from a reduction of progesterone and increase of prostaglandin, we start to increase the rate of depolarization and have continuous upregulation of oxytocin receptors at the myometrial gap junctions. The reduction of progesterone and the increase of prostaglandin, both from the maternal side as well as from the placenta, triggers a change of vascular flow within the endometrium, inducing the initiation of sloughing. This is important because we need to start to have separation of the placenta from the endometrium itself. Otherwise, we run the risk of having hemorrhagic issues within the final stages of birthing. With high prostaglandins and high estrogen and high oxytocin, we start getting myometrial contractions. The myometrial contractions feed back onto the hypophyseal, inducing additional oxytocin release, which induces additional upregulation of oxytocin receptors, which induces additional myometrial contractility. As the myometrium starts to contract, it induces placental prostaglandin release, which induces maternal prostaglandin release, which induces additional depolarization at the myometrium, increasing the rate and duration of contractions. The contractions within the myometrium are peristaltic in nature, forcing contractions towards the cervix. During the dilatation phase, the cervix will open and start to what's referred to as thin. That is, the amount of endometrial tissue at the cervix starts to reduce within the cervical sphincter, allowing it for the full dilatation of the cervix. So, the other thing that's going to come into play here is the cyclic regulation of oxytocin. And so, when the fetal head presses onto the cervix, we get a baroreceptive reflex that is going to start a stress response within the myometrium. At the same time, we're going to have neural feedback onto the hypophyseal, which is going to release oxytocin from the posterior pituitary. Both the stress response as well as oxytocin induces the initiation of peristaltic contraction. When prostaglandins start to come into circulation, we start to increase the rate of depolarization, and when combined with estrogen, we start to have greater amounts of peristaltic contraction. The greater amounts of peristaltic contraction will lead to the fetal expulsion from the uterus and the release of the pressure on the cervical baroreceptors. What we have to remember here is that the increase of prostaglandin release is associated with increase of oxytocin release and the overall increasing strength of contractions in a temporal wave fashion. This is all done on a positive feedback loop, with the stress being pressure on the cervix. So let's go ahead and let's take a look at the stages of labor leading to the expulsion of the fetus.